So now I'd like to introduce Mildred Solomon, President of the Hastings Center, who will be leading today's discussion.
Hello, everybody. It's my pleasure to welcome you to this, our third webinar in the Hastings Conversation Series, Reopening the Nation. Our first webinar focused on the values that should guide reopening, and our second was on the ethical issues related to digital contact tracing. You can still view those on our website or on YouTube if you Google Hastings Center Reopening the Nation. Our next webinar is going to focus on ethical issues raised by vaccine development and deployment, so be on the lookout for that. I also want to mention that we have a non-pandemic event occurring next week on Thursday, June 4th at 11:30 Eastern Time. And I'm going to have the pleasure that day of talking with Alondra Nelson, who's the president of the Social Science Research Council and a scholar at the Institute for Advanced Study in Princeton, New Jersey. Professor Nelson is one of the nation's most esteemed sociologists of science, and she has some very thoughtful insights about the ethical issues related to 21st century genomics. So if you want some content beyond pandemic ethics, please mark next Thursday, June 4th on your calendars. This series on the ethics related to COVID-19 is part of Hastings' commitment to ensuring dialogue between experts and members of the public. We believe that in a democracy, it's essential that members of the public are well informed and participate with experts in making critical decisions about the use of emerging technologies. Today, the emerging technology we're talking about are so-called immunity passports or immunity certification. Governments, industries of all types, technology companies, and application developers are suggesting that immunity passports could be the key to reopening our economies. The idea is that such certificates would be issued to people who have gotten ill with COVID, recovered, and then take a blood test and proves to be positive for antibodies to SARS-CoV-2, which is the virus that causes the disease. People with the certificate, in theory, could return to work, to school, get on an airplane, and resume their social lives. Companies are racing ahead with the creation of these tools, but there are a number of questions about whether they'll work in the first place, and if they do, whether they're ethically sound. Could they become one more way to deepen the already horrible divide between the haves and the have-nots in our societies? Could they be done, perhaps, in a way that preserves privacy and would not enhance surveillance? To help us discuss these issues, we have three stellar experts. I'm going to introduce them in just a moment, but I also want to let you know that I want to repeat what Isabel just said, that we will be pausing during this webinar to take your questions too. So please jot your questions down in the Q&A function of Zoom, and Isabel will be reviewing them there and presenting them to me later in the conversation. So now to our panelists. Françoise Baylis is a philosopher who has done extremely innovative work in bioethics. She's a university research professor, which is the highest possible rank for a professor, at Dalhousie University in Halifax, Canada. She's also a member of the Order of Canada and the Order of Nova Scotia, as well as a fellow of the Royal Society of Canada and a fellow of the Canadian Academy of Health Sciences. Her new book, Altered Inheritance, asks a critical question: what kind of world do we want to live in? Our second commentator is Dakota Gruener. There's an irony here because Dakota is a technologist. However, we've had some trouble with Zoom, not with Dakota, but on the Zoom side, and she has not yet been able to join the meeting, but she is in the process of trying to join us, hoping that she will be here. She's the executive director of ID 2020 Alliance, which is a global public-private partnership that's working with nonprofits, corporations, and governments to promote the adoption and implementation of digital identities for millions of people around the world who are locked out of all kinds of benefits because they don't have driver's licenses and other forms of ID. Dakota launched ID 2020 in 2016. And before that, she had a very senior role at Gavi, a vaccine alliance, where she worked hard to bring vaccines to scale around the world. She graduated from Brown University. She also developed an excellent white paper for the Safra Center at Harvard University on our topic today, immunity certification. Gigi Gronvall is a senior scholar at Johns Hopkins Center for Health Security and an associate professor in the Department of Environmental Health and Engineering at the Johns Hopkins Bloomberg School of Public Health. She's an immunologist. Her work centers on health security and how scientists can contribute to an effective technical response against a biological weapon or a natural epidemic. She's particularly interested in developing policies that will boost safety and security of biological science activities. Dr. Gronvall is the author of a book entitled Synthetic Biology, Safety, Security, and Promise. Now, as I mentioned, immunity passports are already under development in many places, but it seems that all that is happening well before the science can confirm that they're going to work. In fact, on April 24th, the World Health Organization cautioned against immunity passports because the accuracy of antibody tests could not be guaranteed. There are many flawed tests on the market that were let out before they were vetted. But even more importantly, the science is uncertain because the mere presence of antibodies doesn't really tell us whether there's meaningful immunity, how long, whether it's conferred, and importantly, for how long. So before we talk about the ethics, we're going to begin our conversation with the science, with what is and isn't known about potential COVID-19 immunity. And to help us do that, we're going to start with the scientist in our group, Dr. Gronvall. Now, she too will be joining us a little later in the webinar. She'll be joining us live in a little bit, but she was kind enough to pre-record some brief remarks about the science of antibodies and what we know and what we don't know about their relationship to immunity. So we'll begin with Gigi.
Hi, my name is Gigi Gronvall, and I'm a senior scholar at the Johns Hopkins Center for Health Security. Thank you for the opportunity to present to you today. A lot of the information that I'm going to share with you today is presented in much more detail in this document, which is available on our website. It goes into a lot more of the terms and a lot more explanation for what I'm going to talk about. So serology testing provides important information about a person's history of disease. This contrasts with the other kind of testing that looks for the presence of the virus. So most other kinds of testing or PCR testing that looks for genetic material of the virus. This is different because it can be used to diagnose infection, but primarily it's used to see if somebody was exposed weeks ago, months ago, if you have what are called antibodies in your serum that were formed in response to the virus. So early on when you're infected, IgM is a type of antibody, and then later on a type of antibody called IgG. Most of the tests that are available on the market look for IgG. What can serology tell us? They can be used to understand the true prevalence of the infection, to get a more accurate determination of what the case fatality rate is. So it's about knowing what the true denominator is to see how many people percentage are truly very, very sick and who for whom this is fatal. It can help to determine the levels of asymptomatic cases. At least 95% of the cases for COVID-19 have been reported to be asymptomatic, or have symptoms that are not reported. So this can help to get at that number. And it can be used to fill in gaps for contact tracing. So if you know that a group of people were exposed, it can help to fill in the gaps to make a connection between one infected person and another. However, we do have some limitations, and we are still very early on in our understanding of the virus. Even though there's so much research that's going on about it and new things come out every day, we still have some gaps that we need to fill. It's looking like antibodies are important for people's response to SARS-CoV-2. We don't know if it's the only thing that's important for clearing the virus from your body. The immune system is very complicated. There are a lot of different parts. Antibodies are not the only thing that happens in many infections. So we don't know if antibody levels are enough or alone to help clear the virus from your body. We don't know if the presence of antibodies is necessarily enough, or if you need a certain titer, a certain level of antibodies that make it to make you immune. We don't know if there are other methods that people have immunity that don't rely on antibodies. Like I said, there's other kinds of other aspects of your immune system. For some people, T cells may be more important, for example.
Thank you. We will hear from Dr. Gronvall in a few minutes when she joins us live. I want to turn now to Dakota Gruener. Dakota, we introduced you just before you were able to join because of the Zoom glitch, but so happy that you've joined us, and you got to hear a little bit of Dr. Gronvall's remarks too. Now, she's made it pretty clear that we still have to learn quite a bit more, that there's a lot of scientific uncertainty about the claims that are being made for immunity passports, and yet my understanding is that they are being developed and being called for in a number of places. So I wondered if you could fill us in. What is being developed? Where is it being developed? Are there a range of apps? What are they like, and where are they?
Sure, and thank you so much for having me. Apologies for the Zoom issues. So it's a pleasure to be here. Like you mentioned, I'm Dakota Gruener. I'm the Executive Director of ID 2020, and we're a public-private partnership focused on the ethics of digital ID. And in recent weeks, much of that has focused on the ethics of immunity passports or immunity certificates, in part because we've seen these programs moving forward rapidly in so many areas around the world. And in so many different sort of technical designs. The United Kingdom, Germany, Chile are each countries that are actively considering immunity passport programs. We know of work ongoing here in the US. And of course, China, South Korea, areas that were hit by the pandemic early often had very comprehensive, quite centralized, not necessarily privacy preserving solutions that they rolled out that included some element of an immunity passport. A range of approaches are being considered in each of these contexts, or have been adopted in these contexts. So in some places people are considering paper passports, a card, a wristband, some physical signifier of the fact that somebody has an immunity certificate. In other places, the approaches that are being considered are digital credentials. We think that there are sort of significant concerns around some of the paper-based or physical approaches. In no small measure, it makes it very easy to tell from maybe across the street if somebody is wearing a wristband that signifies them as immune or not immune. That from a privacy preserving standpoint is quite risky. And of course, paper-based certificates, there's huge potential for fraud, for counterfeit documents, et cetera. And so, in this digital era that we live in, I think what we're seeing the programs that have the greatest momentum are those that are digital credentialing programs. And then within these digital credentialing programs, I think we see a massive range in terms of the approaches that have been taken. So in some countries, like I mentioned, China, relatively early on in the pandemic, rolled out an application that was a contact tracing application mixed with an immunity certificate of some sort. They were using, it should be clear, it wasn't necessarily based on serological testing, but this was in part using self-reported data around somebody's symptoms and the contact data in terms of who they had been in touch with. And from that, individuals were given a red, yellow, or green, basically sort of symbol on their phone. And, to enter a, any place of work, they had to flash this, and those with a red were, unable to enter, and in fact, usually unable to leave their homes. Those with a yellow had certain restrictions, and those with a green had somewhat unfettered access to move around. In the United States, and in a lot of Western Europe, what we are hearing most frequently is around an approach that is more privacy preserving than that, where individuals' data is generally kept only on their own phone. And rather than flashing some big, easily sort of human legible red, yellow, or green, the information would be transmitted in the form of a QR code or some other machine readable type format. I should note that there's also differences in the technical architecture underlying these. So while the solutions that you or I might be interacting with could feel quite similar, some of the solutions are proposing a very centralized approach. Perhaps the NHS in Britain holding all of this information, people's test results, and basically that database being held by the NHS being the one pinged in the instance that somebody is sharing one of these immunity certificates to test for its validity. That presents certain concerns. Happy to talk about those later. What we have advocated for is that should these programs move forward, and I want to be very clear, we're not advocating for immunity certificate programs, but what we're trying to do is ensure that if these programs move forward, which at this point seems quite likely, that the appropriate safeguards are put around them. And so from a technical perspective, one of the things that we think is vitally important is that that data is decentralized, so that your information remains your own. It's stored locally on your own device, and you don't end up in a situation where there's a large centralized store of data.
Okay, thank you, Dakota. That's a lot of background. Françoise, you and Natalie Koffler wrote a very important paper recently in Nature, and you laid out 10 reasons why you, well, in your own words, you said we can't, meaning that you didn't think the science was there, and we shouldn't employ immunity passports. So first, I want to just stay just for one more round on the science question, and then I'm going to give you the floor to talk about the ethics concerns too. But in Gigi Gronvall's presentation, she talked about the fact that these tests are not accurate. She talked about the fact that we don't know whether they really confer any meaningful immunity, like would it be for at least a year like we get for the flu? We don't know that. But you also, in this piece with Natalie, identified some other technical reasons that you just don't think they're going to work. Could you add a little bit to that side of the ledger, and then we'll move to the ethics?
Sure. So on the technical side, you've already heard that we don't know if you're actually going to be really protected from reinfection. We don't know if you do have this immunity, how long it'll last for. You've heard a little bit about the huge variability in the tests that are available, which means that you could have what is referred to as either false positives or false negatives, meaning you're told that you have enough immunity because you have antibodies in your blood, but in fact they've made a mistake, and you're behaving, however, on the basis of information given. So that's on the technical side. What Natalie and I do is we add to that a couple of practical concerns, which some people are not seeing as ethical concerns, but which I actually think bleed into the ethics really nicely. One of them has to do with something that just has to do with the practicality. The number of tests that would be required to mount any kind of just, fair program is phenomenal, and we haven't seen a lot of people paying attention just to the raw numbers. So let me use Canada as an example. We're 38 million people. That means we would require at a minimum at least double that amount of tests. And the reason we start with a base minimum that you'd have to have double your population is because in theory you test everybody once, but not everybody is going to test as having been exposed to the virus and having recovered from COVID-19. So you got to at least offer people a second chance, right? So that gets you to 2 tests. And people might, quote unquote, fail this on the second attempt as well. So you're going to have to be constantly able to test your population. But, we just say, start with doubling your population. My government in Canada said the other day that they anticipate being able to do 1 million tests in the next 2 years. So what happens to the other 37 million Canadians? Now take that, which is a very small number, apply it to the United States. You have a population of 330 million. You got to offer everybody 2 tests. Where do you have these tests? Where do you have the personnel and the capacity to do this? And is it then going to end up in the private sector, which I think is really deeply problematic if it's not actually supported and available for free to the testing for free to the population as a whole. And the second sort of real practical thing that we raise is a lot of this has come about because people are saying this is key to reopening the economy, that otherwise people have to stay in lockdown. Well, first of all, that's not the only other option, and we're seeing that already because we don't have these immunity passports. And in fact, communities are opening up. They're opening up using the directives from public health in terms of physical distancing, et cetera. But the point that Natalie and I make is that the percentage of people who might even qualify for an immunity passport are too small to count as reopening the economy. You know, what are you talking about? According to WHO's last stats, 2 to 3% of the population. If you look at country-specific areas or hot spots, you might get up to 15%, maybe even 30%. You don't reopen the economy with 30% of your population. The best way to reopen the economy is to get everybody out there, either you know, in terms of the workplace, in terms of potential customer, in terms of potential tourist, et cetera, and use methods which we know have been effective. Yes, they're blunt, but we know they are effective. And that's how you restart your economy, by getting people well educated about the resources at their disposal in terms of masks, in terms of coughing etiquette, in terms of the physical distancing, et cetera.
Okay, Françoise, yes, your point is true that it's maybe not as sexy to do good old-fashioned contact tracing, but we have hundreds of years of evidence that it works. Dakota, what about the concern, the numbers, just the sheer lack of tests for everybody and the low prevalence so far? So, and also not to mention the error rates of false positives and negatives. Any response to that?
Sure. So I think my first point is that I entirely agree with Françoise that to do this equitably and make this accessible, that is predicated on ubiquitous, convenient access to testing. We can't have a immunity certificate program that where some people are given preferential access to testing and therefore have preferential access to the ability to prove their COVID health status. I think something really important to emphasize is that when we talk about immunity certificates, and the paper that we published with Harvard about a month ago uses the term immunity certificates, but in that we do so knowing that it's actually a imprecise and misleading term, because many of the programs that are being put forward aren't actually limited to only those who are immune. So the suggestion isn't that if you are immune, and I think as we've discussed here today, the science of immunity is unclear. Everyone is sort of concerned about a program that is purely based on immunity. Sorry, the challenges from working from home. So instead of these programs being purely immunity certificate programs, I think what is generally being proposed is actually inclusive of 3 different testing statuses. So it could be that somebody has had a serological test that demonstrates that they have a sufficient level of antibody titer in in their blood, and clearly we don't know what that amount is yet, but once that science firms up, that is one potential use case. The second is actually a recent negative PCR test that demonstrates that somebody is non-infectious at this moment and therefore is relatively low risk of transmitting the virus. And then the third, and of course this is also dependent on improvements in science, is when a vaccine becomes available and some proof that somebody has received a COVID vaccine. So if possible, I'd love to widen the conversation today from immunity passports as a sort of singular idea to actually something that's inclusive of each of these 3 use cases. We now talk much more around sort of digital COVID status credentials, or some broader term. I guess one quick point on the sort of testing availability. Completely agree with Françoise that this is necessary, as I just said. But it's astonishing how quickly testing capacity is ramping up. And I can only speak to sort of a handful of conversations I've been privy to since publishing our paper. But a number of even quite small manufacturers that are now on the path to being able to produce perhaps 1 million tests a month. And I realize that when you need when you need 660 million tests, or, as we argue, actually probably significantly more than that, because, for a negative test, or, a negative PCR test, that's something that needs to be repeated quite regularly. That testing capacity is ramping up incredibly quickly. And so I think we need to advocate, and we need to, ensure that ubiquitous testing is a foundation for this. But I think we should be somewhat optimistic about improvements in testing capacity.
Thank you, Dakota. Yeah, just one second. I want to welcome Gigi Gronvall. Gigi, we've already introduced you and shown your video, and we've already had a conversation about a lot of the science and technical parts, and we haven't even yet, and it's already 11:30 something, we haven't yet gotten to the ethics issues, nor have we opened the floor for questions from the audience. So I'd like to suggest that Françoise has a chance to respond, but also, Françoise, really bring in the ethics now. We've talked a lot about the science and the technology, the technical and practical aspects. Raise what you see. Let's wave a magic wand. Let's say there are enough tests. Let's say that it does confer immunity. You still have concerns, even if those things are settled. So bring that in, and then I do promise the audience we're going to open questions to the floor in just a moment.
Okay, so I will do that, but I do just want to say one thing that I think is absolutely key. It's not just the number of tests. You have to then deploy them. You have to get them to people. You have to pay for people to do that. You have to do, so it's a whole lot more. And the other thing is, everybody's talking about this as being preferentially electronic and digital. You then have to assume people have cell phones, et cetera. You have to build in a lot of assumptions. And that, I think, is one of the things that highlights some of the ethical issues we talked about. We, in fact, are concerned about this becoming a novel platform for discrimination, ultimately. And you'll either be discriminating on the basis of socioeconomic class, because people don't have the resources to get themselves to get the testing, or there'll be costs associated with the testing, or they don't have a cell phone. We also believe that it's going to be a novel form of discrimination, partly because of exactly some of the things that have been alluded to, that it will start off as one kind of a thing, and it'll grow into another kind of a thing, whether that's, different kinds of serological data, whether we eventually get to a vaccine, so we're not relying on just immunity. But, I can imagine the next step is, well, why not add the, all the health data? Why not add your life insurance policy to this? Why not add your genetic information to this? And we're concerned about the fact that it comes in at a time where what you're doing is promising people privacy in one sense, and asking them ultimately, though, to trade off privacy for health. And I think that that's a really important thing. So if I can summarize some of the ethical issues, it definitely does start with concerns about a threat to privacy and what it is that people might understand they're giving away in exchange for what they think they're being promised. I think there really is a concern that racialized and marginalized groups will be disproportionately affected, because this actually can be the beginning of some kind of a tracking protocol. In my community, we have had and continue to have a problem with carding of the Black community. And I know that in the United States, you have something similar under the term of frisk and search. We just see this as one more reason to stop somebody who's freely walking about, to be able to demand, do you have the right certification to be out in public? The issue of unfair access just cannot be overstated. Unfair access initially to the testing, but unfair access ultimately to the opportunity to work and to walk about freely. So I think, we're worried about creating a world in which you've got this huge social divide between, under today's language, it would be the immunoprivileged and the immunodeprived. But ultimately, there is no time in history where we have divided the world in two and that it served the interests of those who are already deeply disadvantaged.
Well, that is an excellent place to pause and take questions from the audience. Thank you very much. The questions, I think, Isabel, you're going to state them and then I'll direct them to one of our panelists. Is that what we should do?
Sure. Before I bring up a question or two, I just want to acknowledge many of you couldn't see the video very well, or the slides seemed pixelated. We will be posting, with Gigi's permission, a video of her recording onto the Hastings Center's website so that you can look at it, kind of process the science a bit better, and have some time with it. So the first question that I'm seeing come up a lot is, there's a lot of interest in this kind of idea of the immunity haves and haves not, and have-nots, an interest in that, how that plays in existing marginalized communities, how that might instantiate inequality. But we've also seen a couple of proposals in the Q&A floating the idea that, in fact, perhaps marginalized communities have been exposed more to COVID-19 because they're less able to sequester. And so a couple of people in the Q&A have suggested actually that this might be an equalizer, that it would let people who are immune get back to work. And I'd be curious what the panelists have to say to respond to those propositions.
Françoise, you brought the haves and the have-nots up. So why don't you take a go at that first, and then we can see if Dakota and Gigi have comments on it as well.
Well, I just think actually this is really kind of twisted logic. We're actually going to try to say to people that don't worry, the harm of getting infected, possibly getting very sick, that actually makes you privileged. You're the person who's going to benefit. You're going to get out to work. And that, in fact, really leads to one of the things we haven't talked about. It's actually finding a way to incentivize behaviors that are actually contrary to public health. So I find that a really problematic, let's say that, a really problematic way of trying to turn what is clearly a harm into somehow a backhanded benefit. And that's something that, you know, we've seen in another context. I'm not the person who's done that work, but Catherine Oliverius has looked at a similar kind of scenario in the United States with yellow fever, where the world was divided into the acclimated and the unacclimated. And guess what? The, you know, people who end up losing in that scenario, and that's in a context where we don't even have the technology to test who really does or doesn't have yellow fever. It becomes a way of pretending that the objectification and the racism was in fact somehow grounded in data and fact, and therefore you could, for example, send Black people out to work because after all, they're not going to be exposed to risk the way we fragile people are, so we'll stay in our homes while other people go into dangerous areas. So, I mean, that's just one kind of very dramatic example, but it really kind of fits this approach to somehow turn it around and suggest that this is going to privilege people. It's not going to happen in that way. I'm going to make a firm prediction, and I'd bet a lot of money on it.
So this historical experience of using a biological marker, in particular immunity to yellow fever, was happening in the 19th century. And particularly a good example of it is in New Orleans. I don't know if there's anything that you could direct people to read about that, but I think it's a fascinating historical precedent that we should.
Excellent work by Catherine Oliverius, and I'm sure you could just Google it and find her work.
Great.
You mentioned that as well, her work and our strategy for how antibody testing should be rolled out for the nation, that whole experience. There's some big differences between West Nile and what we're dealing with here. Not West Nile.
Yellow fever.
Yellow fever is caused by mosquitoes. West Nile too, but.
Yeah.
So
Isabel, do you have, oh, Dakota, were you going to say something?
I was just going to jump in quickly in response to Françoise. I think, first, I completely agree with you if we define it in terms of truly just immunity certificates, right? If this is just a schema designed around ensuring that those who have been exposed have some presumptive level of immunity, if they get released, if you will, back into day-to-day life, that incentivizes potentially infecting, risk of infection, and is, I think is generally a pretty frightening principle. I think it's also just not viable. And you touched upon this earlier. I mean, in the Bay Area where I'm located, we only, an estimated 1 to 1.5% of the population has the antibody. And so, if we're thinking about, balancing the risks of misuse and the risks of misuse in terms of, what are the needs to reopen the economy and, how is it that we, do resume some degree of normal life, clearly an approach that is purely around immunity certificates, there isn't a particularly great social benefit. You're not going to get many people back to work. And, some of the risks that you're describing are significant. But again, if we expand this to think about it for multiple different use cases, and I think particularly around a recent negative serological test, or as some of the organizations are actually developing sort of self-attested records of your symptoms, which presents very different concerns around sort of false degree of security. I think that it's a very different thing. Suddenly you're not privileging those who have been infected. You're saying anyone who we believe has a relatively low risk of infectiousness can resume their day-to-day life. And so, you know, from the
we are privileging those who have access to the testing. So just at step one of the process, you're privileging who can get in line first to get access to the testing. And that's a huge barrier for a significant portion of the population. And I think what I'd, be really curious to have you respond to, Dakota, because I actually believe deeply that we agree on two fundamental things. We're both committed to protecting health, and we are both committed to not compromising privacy. So I think we have that in common, which is really positive. And when I looked at the report that you prepared, the thing that's really interesting, and you said it again today, it all starts with a conditional statement. If we must have them, if we're going to do this thing, right, then. And as a philosopher, when we have conditional statements, we look at the hypothesis, the if part of the statement, if we must have them. And what Natalie and I are doing is we're asking people to say, well, we don't think we have to have them. We don't see the benefit. We know there's a lot of tech companies out there that can see a lot of benefit, perhaps in terms of profit or other things, but we're saying, what's the social benefit? What's the benefit to the community? And I will grant you, if we're talking about a vaccine passport, and if the vaccine is available to everyone for free and for a discrete purpose, like perhaps going into high-risk situations, I can see a value. I can understand that if we must have them. If we have a vaccine, it's universally available, it's free, it's a high-risk place, I understand it. But that's not what we've been talking about. So I can't even get off the ground with confirming the hypothesis. So I'd love to hear your response to that.
Sure. Very briefly,
I mean, I think
we need to go back to the audience. We have a stack of questions coming.
Sure.
So to put it in a sentence.
Sure. The very brief response is that we're seeing these programs move forward. And I think our sentiment is that the greatest risk stems from us simply trying to kind of stymie them and not engage, and instead having these things move forward in a manner that doesn't include important safeguards. And so, the concern is one of,
Thank you. That was perfect. Okay, Isabel, another question from a different.
So to follow up on Dakota's points about if this must go forward, and certainly we can acknowledge that there are many reasons why it shouldn't, and we can consider stopping some arguments there. But if this must go forward, there's kind of questions about what type of oversight would exist. Is there any oversight with teeth, so to say, that's not just a recommendation from a governance body somewhere that doesn't have any legal force?
Gigi, as a biosecurity person.
happy to jump in here.
And Gigi, as a biosecurity person, you might have some ideas about how we hold players accountable for whatever rules we would set up and what kind of teeth there can be in monitoring.
I mean, it looks like there's, Dakota seemed like she was just about to jump in. I think that there's a pretty wide leeway for public health and what the decisions that you could make. And so I wouldn't rely on that as much as my concerns would be just automatically like, I was not part of the initial discussion, but my concerns are more about the technical basis that you could even have a passport and how long you would be able to hold it. There's a lot of information that you would need to kind of hold on to because we don't know how long immunity is going to be durable for. So how are you going to collect that? It's a research project as much as anything else.
Okay, Dakota, I'm sorry. I think you wanted to say something and I might have cut you off.
No worries. So I think my point there is really just that enabling legislation, trust frameworks are critical for these programs to move forward in a careful manner. And so I think you're right that at the moment there aren't significant legal teeth around how such programs would move forward. And so one of the things that we have we've advocated for and that we're helping various jurisdictions think through is how you put that enabling legislation around this, ensure those protections, ensure that there are those legal safeguards.
And what safeguards would you want in that legislation?
Sure. So I think some of the important ones, and there's a laundry list of these, but who is eligible to issue a certificate? Is that healthcare providers? What we're seeing is a huge number of employers who are thinking of providing testing at their work sites. Does that mean that an employer is able to, to issue a certificate of a recent negative test result? What are the issues around liability if somebody issues a certificate that turns out to be, incorrect, fraudulent? what are the limitations on data storage? How long can that certificate be held? I think one important thing, and maybe this is a separate question, but Gigi, to your point, the technical architecture really matters here. And so if you're designing this as essentially a centralized database, then there are very clear restrictions that need to be put in place around how long that data can be stored, who has access to that data, the security, et cetera. What we advocate for, and what I think very strongly believe is necessary here, is that the data remains with the individual. So this is not around, the idea is not developing some large centralized database, but instead of having a verifiable credential on your own phone that would allow, or there's paper-based methods to have a backup in case somebody doesn't have a phone. That's another important equity issue. But that verifiable credential stays with you. And so, it's your choice to jettison that information at any point. You have the ability to share the information granularly and selectively only with who you want to share it with. And so you end up with a very different set of concerns around privacy and the sharing of data.
Okay, so no centralized databases. Françoise, and then we're going to go to the next question.
Yeah, so I think I can make this point very briefly. In the introduction, you heard that I've just recently published a book on genome editing. And in that book, one of the things that happens is that many people argue, well, people are going to do it anyway. So we just have to arrange the world around the fact that people are going to do this anyway. And what I and a number of others have done is to say, wait a second. You're moving far too quickly to answering the question of how. How are we going to do this ethically, right? And I think that that's what I'm hearing. Dakota's very committed to saying you want to make sure that it's done ethically, done well. I think Gigi's saying the same thing. But those of us with a background in philosophy or science and technology studying are saying you're asking the wrong question. The first question is whether we should be doing this. And only when you answer that question in the affirmative do you then move on to the second series of questions. How do we do this ethically? And so I think there are a number of us that are trying to say we haven't had the right conversation yet, and collectively come to the conclusion that this is something we need, that this is something we must do. And I think it's wrong to allow the private sector to answer that question for us, and then to think that society, via its governments, just has to respond by putting parameters that would, somehow satisfy certain kinds of ethical or social concerns. So I just want to say the question here is whether we should be doing it, not how. And only once we've answered the first question in the affirmative should we really be entertaining the how questions.
Thank you for putting that so directly. In other words, I think it's fair to say, and correct me if you see it differently, a whether question is really an ethics of ends. Is this something, a goal or a purpose that we think is morally worthy? And a how question is an ethics of means. Okay, now we've decided that we have a worthy purpose. We're going to try to do it in the most ethically sound way. So I think that's another way. With whether or if is also an ethics of ends or an ethics of means. Where are we locating ourselves?
Absolutely. And for me, it takes me back to my core question. What kind of world do you want to live in? I don't want to live in a bifurcated world that will continue to hold people down. And I view this as a risk in terms of building that better world.
Isabel, next question.
So there's been some reference, Françoise, you talked earlier about how these proposals kind of build on existing trends of monitoring of marginalized communities, of for example, stop and frisk. There's also interest in the Q&A of people wondering, how do these proposals build on kind of a broader societal trend of increased monitoring using big data? And wondering if one of you could talk a little bit about how what we're looking at now relates to these broader trends.
Do one of you want to take that?
I saw Dakota nodding, and I've had a lot of airtime, so Dakota.
I can jump in and offer a few thoughts. I mean, the first is that I think contact tracing and the sort of digitally assisted contact tracing that we're seeing being rolled out certainly is around sort of aggregating large amounts of data and monitoring that, and that is the intent. And I think many of the programs are being put in place try and take the most privacy preserving approach that they can to do that. But certainly what they are doing is using big data as an approach to monitor and understand people's contact tracing. That's why it's so essential that these programs have a shelf life and one that's appropriate for for this setting. I think, again, and I feel like I know I've sort of banged the drum on this, but this is where the technical architecture of such a program would matter so much. You know, what we saw being done in China, where you had, you know, either self-reported information combined with contact tracing, and people were truly just assigned this red, yellow, or green indicator with no real understanding of how it was that that came to be. Clearly, in that case, that is taking, you know, big data, monitoring it, and making determinations that have profound effects on individuals' lives. In the, you know, in this architecture that I'm describing, where the data remains with the individual, there is no aggregate data that can be rolled up and monitored. And so you really don't have big data. If anything, you have data that remains, you know, just with the individual.
Thank you. Isabel, do we have some more questions? I think I see a list.
Yeah, so people have also been, interestingly, several questions have come in about a population that's often not talked about when we're discussing digital technologies around COVID, and that is adults over 70. So there's a lot of interest in kind of what would the implications be of these proposals for that population? Would they help that population at all if they were successful in some world? Or would they kind of just contribute to this population staying inside and not really being able to interact?
So Natalie and I speak to that issue, and we say that if the philosophy in terms of pushing this forward is reopening the economy, we say who are all the people likely to be left behind, because they're not seen as people who are contributing to the big picture goal of reopening the economy. We talk about the elderly, we identify young kids at daycares, for example. We talk about people who are homeless, people who have problems with addiction, with mental health, etc. We can actually see very clearly why these people would end up at the back of the line, so to speak. And if we're talking years to get access to testing, then we're saying, really, what do you imagine saying back to these people, why they would not be able to have freedom of movement? And I think this is really, really important, because that's what we've been talking about generally. It's really a kind of a fundamental right that you're talking about restricting, and it's, we would argue, introducing a harm without what we can see as any kind of a proportionate benefit, which is why when we said, if you're talking about a vaccine where you've got robust science behind it, if you're talking about it's universal and it's freely accessible, then you've got the issue of choice. And if you're talking about high-risk places where this would be used, then you've got a potential benefit that we can understand. But we just don't see how that translates back here. And yes, the elderly would be a very identifiable, discrete community likely to be harmed.
Can I just add that, so any approach to contact tracing needs to be performed and developed with public health so that it actually works. And so I think it's just to make sure that that is out there, that it's not, you know, that it's likely to be a real contact. I mean, because this is the kind of the bread and butter of public health, and this is what, you know, people train to do, and it does require a little bit more personal involvement than just digital.
Yeah, and I also would like to be clear that Natalie and I are in support of contact tracing. We think that is something that's worth investing in because, again, it's tried and true in terms of addressing this issue. And I would say more generally, I think many of us are acutely aware that we have not done well by our elderly population. And, you know, I'll speak just in my community. I'm in a province of about 1 million people in Canada. I'm in the city that has had the most deaths. We've had a total of 59 deaths, and all but 6 of them are in one institution, and that's shameful.
Isabel, do we have some more questions? We have a few more minutes.
Sure. So there's also a question about someone interested in comparing what we're talking about here around immunity certification with what already goes on in grade school for children and vaccines. What are the major differences between those two instances? Why are we so concerned for immunity passports for COVID versus for the typical kind of vaccine certification that already happens?
That's a great question. I actually had that question myself when I started studying this topic. So who wants to jump in for that? Why is vaccine certification required in most places, in most states, and I think most provinces, different from immunity passports? or is it?
Well, first of all, it's something that it's available to everyone. So I have a yellow WHO passport thing. It literally goes into my passport, and border control people will look at it to make sure that I've been vaccinated against yellow fever when I go to some countries that require that. And it's a matter of public health. I mean, that is, and we require medical workers in different situations to be vaccinated against influenza. It's the same kind of thing. It's something that they can choose to do. It's available to them. It's a very low risk, and that's comes with the job or comes with the travel.
I think you've raised the important point, which is with vaccination, you have actually robust data. So we actually can answer the questions about whether you do or don't have immunity and for how long. And I think the other thing that's absolutely key is that there is an issue of choice. I can choose to be vaccinated, or if it's a place, for example, that wants my yellow fever vaccine and I don't have it, I don't have to go, or I choose to get vaccinated. So there's a different kind of thing in play. And, I do want to say that although I understand, that there's, an interest in being able to speak beyond immunity passports, I think the ethical issues between, vaccination and this sort of serological status is significantly different. And I do believe that there are contexts in which we should require vaccination in the future when we have such a thing. And I think one of the things that will be interesting, and maybe the Hastings Center will bring us back in a few years if there is a vaccine, would be to have a question about mandatory vaccination. We don't have that right now for our healthcare providers who work in high-risk settings, where some of us have asked questions about whether or not it should be mandatory if you're going to choose to work in certain settings. So I think there's a really important question. I just want to say it's a different one because it brings up different ethical issues than this idea of immunity passports.
We're going to anticipate some of those ethical questions related to vaccine in the next Hastings conversation. And there's a wide range of issues, both how we study vaccine development ethically, but also fair access to it. You've already stated the importance of the universality of vaccine availability as a prerequisite for an ethical program. Okay.
I mean, a very quick comment there, just in response to both Gigi and Françoise. My background actually is in immunization policy. So, I've spent a lot of time thinking about this, and I would question, the degree to which vaccines truly are, optional, right? I mean, that is true if you're getting a travel vaccine, you're choosing whether you want to go to a place where there's endemic yellow fever. For most children, proof of vaccination is mandatory for them to enroll in school. And so when we think about, I think I completely agree that the universality of vaccination is important such that we can have these types of passports and, I think mitigate some of the ethical concerns we've all discussed. But I would kind of question this notion of, we truly get to opt in, whether we want to participate or not.
On that note, on a public health question, a public health ethics question, we have about 30 seconds left. So I'm mainly going to use those 30 seconds to encourage people to distribute the hot link to this wonderful conversation, which will be up on the Hastings website later today. All of the things that we're doing with this are meant to engage and educate the public. So the more you can distribute the content that Françoise Baylis, Dakota Gruener, and Gigi Gronvall have brought to us today, the better, the more people that see this. It was a great conversation. I want to thank all of you very much. And I think it's exactly noon, so I'm going to sign off. Thank you.
Thank you very much.
Thank you.
Thank you.
Of course, there are questions we didn't get to today, so if you'd like to continue the conversation, check out Twitter using the hashtag #EthicsForReopening. Thanks, everyone.